following PowerPoint is going to give some brief information on the major differences between the pediatric and the adult respiratory system. And then we'll give you a review of the signs and symptoms of respiratory distress, particularly in children. So how is the pediatric or the airway of the child different than that of an adult? So here are some major things that we have to think about when we're caring for young children with regards to respirations. First of all, their upper airway is different in several different ways. First of all, it's shorter and much narrower. And in general, if we look at the size of our pinky finger or our little finger, that is about the diameter of the trachea in that child. Because of that narrowing and that shortening of that airway or that trachea, they have a greater potential for obstruction much more quickly. And resistance is a problem because those airways narrow even with the slightest of inflammation. So we can go from a rather small diameter to an almost closed diameter very quickly. Additionally, the trachea divides into the right and left bronchi higher than it does in an adult, and I have a slide of that coming up. And something of particular interest is the right bronchus at the bifurcation where it branches off. It has a much more acute angle than it does in adults, and that you will be able to see in the picture that I have on the next slide as well. Of note as well is that newborns are obligatory nose breathers, which means that they only use their mouth to breathe when they cry until about 2 to 3 months of age. They won't even open their mouths to breathe if you plug their nose. Why is this important? Well, if a child comes in with RSV or another respiratory condition that has a lot of upper airway congestion, or a nasal passages are full of secretions, that child will have a very difficult time breathing because they don't automatically open their mouths to breathe. So we need to really work to keep those nasal passages open, either via suction or the bulb suction syringes that we use. So this is a picture of the trachea position, and you notice that that right mainstem bronchus has a very steep slope in that child. And you see where it branches off, almost really just below those clavicles, so a good bit higher. And it's something that we need to remember. This gives you an indication of the diameter, and what I want you to take of note here is that notice that if we have a simple 1 millimeter of inflammation in that airway, it actually constitutes 2 millimeters decrease total, because if the whole airway is surrounded with a 1 millimeter inflammation, then we actually have to count to 2 millimeters for that diameter, and that picture gives you a good indication of that. So again, infants' airways are small, children's airways are small, about the size of that pinky, and so that 2 millimeter difference, or that difference of even minor swelling, can really be a significant impact on respiratory status. The lower airway differences, so alveoli are developing in the fetus up until about 36 weeks of gestation, and they continue to develop at that point till about the ages of 5 to 8, somewhere in that late preschool, early school age bracket. So by about 5 months of age, those muscles that smooth muscle in that airway is able to bronchospasm. So as early as that, we can get kids having that reaction. Remember that we are belly breathers until approximately 6 years of age. And remember, we've talked about that, how they have that big sway back and that big belly. And as that goes away in that late preschool, early school age bracket, we also go to using our intercostal muscles. Children generally consume more oxygen than adults do because they have a very high metabolic rate in comparison. And remember, children will tucker out faster. So the harder they work to breathe, the less time they have to be able to compensate by using that extra work. They have less glycogen stores overall than an adult does, and that's why we say that children's respiratory statuses bottom out much more quickly. They tucker out a whole lot faster than adults do, and it's because they don't have the reserve that we do. So let's talk about some signs and symptoms of respiratory distress, and there's some good pictures there on the left. Tripod positioning really is the little girl in the middle picture there. She has her arms down in front of her, and some kids will actually really almost tripod leaning forward. Adults will do this as well, and it's in an effort to try to open up that airway. Tachypnea, tachycardia go without saying, adventitious breath sounds you've heard before, and in our lecture I will have recordings of a lot of those sounds. Inability to speak in full sentences is really important for kids. They may not be really able to even complete a sentence to tell you how they're feeling. Color changes, that top picture on the left shows definitely cyanotic lips or circumoral cyanosis. And restlessness, that is one word I want you to pay attention to. To be restless is a sign of respiratory distress. Sometimes we think restless can mean other things, but especially with regards to the NCLEX exam, restless is seen as a respiratory distress. That bottom picture on the left shows a really good picture of intercostal retractions in an infant. So there are stages of respiratory distress. I'm not going to belabor these points, but in mild respiratory distress, we're really just trying to compensate for what we've got, and you may see those following signs and symptoms. As we progress to a moderate stage and we're beginning to really decompensate and get more tired, our signs and symptoms, as you would imagine, start to increase in the number of signs and symptoms we see and in the effort to try to compensate. And finally, in severe respiratory distress, which does turn into respiratory failure, we have got those grave signs, especially neurologic signs, where the patient has become either comatose or unresponsive. So let's talk about respiratory failure. And basically, respiratory failure happens when the body can no longer make up for the difference. We can no longer compensate for whatever it is we're having to overcome. So what happens is hyperventilation takes place. Our oxygen needs basically are greater than our oxygen intake is. Airways can be somewhat occluded, so whatever the cause may be, whether it's an asthmatic attack, whether it's an obstruction, whether it's filled with fluid, etc., we have an inability to keep that airway opened, and that will in turn affect the ability for O2 and CO2 to be exchanged at the alveolar level. Remember, the alveoli are where O2 and CO2 is exchanged. So in respiratory failure, we consider that beginning stage when hypoxemia and hypercapnia result. So once hypoventilation has taken place long enough, we start to see those changes in the blood, and we consider that a respiratory failure state. And therapy really depends on how the patient is presenting and at what point we are hitting them. We need to reverse that hypoxemia. So in many cases, we will give oxygen. Obviously, the method by which we give it, we could give it by mechanical ventilation if it's bad enough. The baby down there on the bottom left or toddler on the bottom left is certainly ventilated. The baby on the top is getting CPAP, and CPAP may work in early stages to compensate and to help and prevent us from getting farther down the path of respiratory failure that may require mechanical ventilation. These children are often admitted to the PICU, and as level of responsiveness decreases in these children and in adults, but in these children, it can happen much more quickly. Our ability to keep that airway open significantly decreases, and therefore we may electively choose to intubate earlier in an effort to try to prevent that airway from closing off.